Well, I think we have a lot of material to discuss. Pierre, could you change the program of the day? We could spend the rest of the day in discussing what have been exposed to us. So we have about a good 35 minutes. I will open the floor immediately. Should you have questions, comments to raise for the... Yes, sir. Maybe you state your name.
Yes, I'm Michael Kramer. I've been a member of this department for 37 years or so. I spent my whole professional career here, and I enjoyed all of the panelists' comments. I just want to, partly to kind of convey at least my perception of how the McGill situation has evolved over the last several decades, and my concerns about some of the comments that I heard and where McGill should be going, because part of the reason for this is not just to celebrate our last 50 years, but to think about the next 10 or 20 years. And many of you know in the room, but perhaps not the panelists, that this department has grown quite a bit. And during the 80s and 90s, most of the growth occurred not within Purvis Hall, where the department center is now, but in the hospitals, and that's because McGill was in a hiring freeze, and partly because of our provincial funding agency, the FRSQ, and partly because of the hospital's foundations. A lot of not just clinician scientists, but also basic PhD epidemiologists and biostatisticians actually joined these research institutes at the hospitals. And a lot of the strength of the department and a lot of the teaching from the department has occurred as a result of these hospital-based. So we're dealing with that now. And in my view, that has been a strength, both for the Department of Epidemiology to have some of these people who have contact with clinician scientists, even if they're not clinicians themselves, in bringing a clinical perspective to public health and population health. And it's been enormously helpful for the clinical departments who now don't just focus on the disease of individual patients, but have decades now of being aware of the importance and of caring for the population, of systems thinking, of thinking of real population health in addition to the health of individual patients. So that's kind of the context here, and I think that has been the strength, that kind of duality between the central department of epidemiology and biostatistics, or the various names that it's gone through, and these hospital-based research institutes that have, in addition to clinical scientists, basic epidemiologists and biostatisticians. I'm a little bit concerned that strength that we have, both on the clinical side and on the population health side, could be threatened by the formation of a school of public health. So should we go the way of the University of Toronto or the University of British Columbia, or should we build on the strength we have and continue to try to strengthen that model? And I just would be interested in the panel's reactions to that.
Thank you. To you?
Sure, it's a very important worry. I'll just tell you a little bit about our situation. When I came to Canada, I realized that the configuration of the distribution of faculty is very different than it is in the US. Jim Curran runs one of the most successful schools of public health in the U.S., has a large faculty that are all based in the School of Public Health. A lot of them, are required to write grants, which is a little bit, you worry about that, but they have, their core is in the School of Public Health. Our school now has over 600 faculty, but only about 80 of them are actually paid in our core in our school. The rest are, like you said, distributed in the powerful research institutes in the hospitals. They're in Cancer Care Ontario, they're in Public Health Ontario, they're in the Institute of Work and Health, all over the place. So we have to figure out how we actually operate, what our expectations of them are in terms of teaching and service. Research, of course, is they're hired to do that as a research scientist for their home institution. And the benefit for them, of course, is they get access to students. They get to write CIHR grants, which require an academic affiliation, et cetera, et cetera. But it's a relationship that you have to manage very carefully. Now, when we became a faculty in 2013, our mantra was actually becoming a faculty will allow us to become an equal partner in the things that we have to do together, and together we can be more powerful. And I said that over and over and over during my first year at the School of Public Health. Now, it really helped that the Dean of Medicine understood that. It really helped that we had a president who was an MD, MPH, and really sort of understood that. But certainly there were still lots of fears about exactly that. Oh, we're going to move away from our clinical colleagues. We'll lose that special strength. But the other thing we did is that we created a special division called the Division of Clinical Public Health, which is specifically a home for clinicians who practice, but whose main area of scholarship is in public health. So instantly it created a home for people who are scattered all over and had very little mentoring guidance on what their career pathway was going to be like, or the kind of community that allowed the departments, wherever they were, to judge their scholarship because what they were doing was so different. And the second thing it did is that it created a division where the mission was specifically to figure out what's the role of prevention in public health and a sustainable health system of the future, and to do scholarship on that. And that for us has been very successful. It's been able to give us an actual institutional unit where the School of Public Health and the medical school can work deeply together. That's the home of the preventive medicine residency, the occupational medicine residency, the nascent MD and PH program that we're growing, and it provides, you know, a framework in which we actually can then partner going forward.
Other comments on this question? Yes, Mr. Shapiro.
Stan Shapiro, Professor Emeritus in Epidemiology, Biostatistics, and Epidemiology in Health. Oh, that's a bit of going back. I think my question's for Dr. Spencer, but I think it's really for the whole panel as well, in that the title of this session, I think, was Schools of Public Health in the 21st Century, the role of them. And for many years, I would participate in the summer program at the University of Michigan in epidemiology and public health. And there was a period of time in the 90s particularly where colleagues around the table at lunch would sort of bemoan the struggles they were facing at their schools of public health that were under threat of closures. So what I'd like to know is what lessons were learned from that period of time, because I think that was a generally broad difficulty that schools of public health were facing, and how has that strengthened the going forward in terms of schools of public health?
So Jim said there's been a doubling or more of schools of public health, certainly since I came in 2000. I think we've had 2 schools that have dropped back to be accredited programs. I guess what I'm saying, I'm not aware of the struggles. I think even in financial hardship, there have been some constants. Number one is everyone said there's huge demand from students. Millennials, they want to serve. They're very interested in global health. And many of them are interested in degrees, and we've seen increase in applications almost everywhere, every single year. Secondly, despite there is certainly pressure from research funding, which is another major funding stream, particularly from NIH. And I can't answer one by one, but I think people are managing in this, and again, Jim could have a much better idea doing it. The third income stream, many of the public institutions get monies from state governments, and that's been very, very problematic. But I don't think it's resulted in threats of closure. I'm trying to remember, New York Medical College was a school and dropped back to a program. The University of Hawaii dropped back to a program. That was for many political reasons, but those are the only two. No. That was a threat from the university. They had decided that they wanted to close it. So Jim can comment on this as well, but we actually see not the I mean, I think your question is wrapped up in, well, what are we going to do and what are the risks of what we do? And all I can tell you is I think there's value to schools of public health within universities, and whether or not McGill decides to do this or not, there's always going to be some risk. In the UK, when I came, I sat down with a British ambassador, the American ambassador to the UK, Admiral Crowe. And what he said to me, I'll never forget. He said, the British don't like to change at all, and Americans like to change for change's sake. And I found this so true because every time I brought up something, it was always, well, tell me how it's going to be better. Are you sure it's going to be better? And I'd say, well, of course I'm not sure it's going to be better. I don't know. Anyway, Jim, you may want to.
I guess I'd combine comments to both of the first comments from the audience. The first thing is, we of course don't know how McGill should organize, or whether it should have a school of public health separately, because you have such an eminently successful department. Our school has 200 adjunct joint faculty from our School of Medicine. I'm jointly appointed in medicine and nursing. All of our deans are jointly appointed. We're on the same campus, and we must continue to collaborate well. Having an independent School of Public Health for Emory has strengthened our capacity to collaborate because we've been able to grow the disciplines that could not grow as quickly in the School of Medicine. But we have not stopped any of the collaborations in our School of Medicine or tried to transfer everybody that are in medicine. We like to have epidemiologists and biostatisticians in the School of Medicine with joint appointments. The second thing is that in terms of threats, as a dean, in the United States, we have three big threats. One is the cost of medical care and the huge transfer payments from our health care system to our medical school. So our medical school in particular is under threat from the costs of medical care and what that does to the salaries of physicians, what that does to the viability of medical education and the concerns of costs of care in the United States and reorganization of care. There's a lot of market consolidation. Our university is exploring divesting itself, a health system from the university. And this is a huge threat, but it's also a huge distraction to the medical school. In public health, we're more used to our poverty. And we are a little bit, although we're involved with this, we're not as directly threatened by it. The second thing is the cost of higher education. And in private universities and public universities, this is a huge problem that all of us face and public health faces. And then the third issue is the leveling off and decline of research funding. Schools of public health actually can do a little better because we're more used to foundation funding from the Gates Foundation and others than our medical colleagues. So we have a little bit more of a buffer. And actually, our School of Public Health has increased funding during a time when the medical school has seen declines. So I think that we are all facing these same issues, and the issues are real issues. They're not as much a threat to closing a School of Public Health as one might think.
Thanks, James. Madam? Okay.
Ariane Marelli, I'm a professor in the Faculty of Medicine, and I have an MPH from the Harvard School of Public Health. A newly joined member of this department, but very proud to be. I was wondering, and this question is addressed to any of the panelists, an additional dimension of the public health messaging and aggregate of knowledge intersection, I think, is the growing interest in patient-centered care. I didn't hear anybody comment about that, and the reason I think it is important to the public health mission is because I think it has really the potential to shift the distribution of the shared economic burden. It has the potential, not necessarily, we haven't yet seen that, but it has the potential, and somebody mentioned Don Berwick. It's very much part of the mission statement in a lot of of schools, and I wondered if anyone had some comments about that.
Thank you.
On my list of priorities, which I didn't get through because there wasn't enough time, the whole area of integrated healthcare, which in our parlance includes what you've just referred to, is a major threshold issue. So Australia is a country that has a national health insurance system. It is a country that is facing the tsunami of NCDs and the way in which this is already having a massive impact. The implications for the future productivity, what in Australia is called the intergenerational report, which from an economic point of view illustrates very clearly that future healthcare will be unaffordable because there won't be enough income generation because of the workforce, lack of productivity and so forth. So this is, again, at the interface between clinical medicine and public health, and the way in which health systems and health services are both innovated, evaluated, and then implemented. And from my point of view, this is where there is a real leadership role for public health, and it's very much one that involves partnership with medical schools, with healthcare systems, with the public and private sectors in those systems such as our own, where there is very strong both public and private sectors. So it is a major issue. And on that, Mike, I just wanted to respond also to your point. Absolutely, there has been an enhancement of those collaborations with the medical schools, with the different medical teaching hospitals and so on, the part of our network. They've enjoyed and have benefited from having an enhanced profile of public health within our system, and actually has led to a substantial increase in those collaborations. It's not just in our system with the teaching hospitals themselves, it's also with the research institutes. Some of those research institutes, as you know, in paediatrics are very strong, and their growth internally within the public health mission within a complex basic science, clinical and public health research institute has been enhanced by having a strong university presence within public health that has actually partnered with them and helped them with their internal advocacy as well. So I see this more as an opportunity than as a threat. Obviously I don't know the Montreal system as intimately as you do, especially since the 30 years have elapsed since I was here. But I think in general terms that this should be a real opportunity for you.
Okay. Any other comments on that question, Howard?
I interpret the patient-centered care question in two ways. One of them is that I totally agree with Terry about essentially the fragmentation of how patients are cared for, and not only the need for integration, but to bring in sort of a social science perspective on patients and role in society. But I guess there's this different perspective to patient-oriented care that I'd like to inject that relates to a movement that our school has started last year. Let me ask people in this room, who here feels like they're free of any disease or mental health condition? Raise your hand. Raise your hand. Raise your hand. Okay, there's 1, 2, 3, 4. Okay. Okay, now let me ask a second question. Who here...
They're not really conscious about it.
Yeah.
That's the problem.
The second question is, who here feels healthy? Raise your hand. Okay. All right. The point is very simple, which is that, in fact, you can have 1, 2, even 3 chronic medical conditions, but be functional, feel happy, and feel healthy. And our scholars have been working on a new definition of what health should be. I think the WHO definitions of health are a bit antiquated. And it's created a new field called salutometrics. And that's part of what we see as patient-oriented care, which is understand what the patient needs and feels. Because in this age of multimorbidity and chronic disease is, well, excuse my basic science and medical colleagues, incurable by definition, we have to think more broadly of what the end game goals are in society and what our outcomes of interest should be.
Thank you. So, sorry, sir. Michel first, then I come back to you, and after that.
Michel Rossignol. associate professor here at the department and a clinician at the Health Technology Assessment Agency in Quebec. Many of you interpreted the increase of demands of admission in the recent years as an increased interest in public health. I would ask you your ideas of how much of that is vision-driven or market-driven, and how much we need to be critical and or reactive facing this increasing demands of admission, which puts a lot of pressure on teaching and resources.
Who wants to react to that? James?
Could you clarify that a little more?
From what I heard, almost all of you said there's a big increase in interest in public health. And we see that at the department obviously as a big increase in demands of admission every year, almost doubling in recent years and increasing. Michel said that too. And I wonder what is behind this seemingly increased interest, so that we can adjust and our teaching and our model of public health to these demands. Or is it legitimate?
Yeah, I'll take a
Could
crack.
it be partly a kind of a change in the culture of the new generation coming up, who might sort of develop a different vision of health and intervention in health? And that's my first reaction to your question. But any other comments on those?
I'll take a crack at that. We have about 7 applicants for every slot and about a 75% yield. So the provost is very happy to say, "Oh, keep growing, get more enrollments. We get more, investment. Each student is worth something like $22,000 in Canadian dollars from the Ontario Ministry of Education." The question is really, what's their job prospects? What are their career futures like? It's been a bit of a disappointment to hear rhetoric from on both the provincial and national side that there's going to be an exercise in looking at national and provincial workforce needs, but not seeing anything materialize. So we do have to kind of do it ourselves. But it's also an era where the role of public health professionals is changing, so it's hard to apply today's standards and what a public health worker is to envision what the future is going to be in 15 or 20 years. So there's an uncomfortable space that we're in right now that eventually the market will decide. I will say, though, is that we also created an undergraduate initiative, and in the recognition that many of our students, whether they're just here for some courses or they're here for a degree, will end up applying to medical school or applying to law school or going off to the private sector. And, our feeling is that that's a good thing because, in fact, because of the need of sort of public health in all policies and the need of an educated professional workforce in all realms of society, it's good to have literacy in public health because those people will be making decisions that will ultimately affect public health. And that's a ideological reason why we should embrace a larger student population.
Thank you. Michel, vous vouliez...
If I understand your question, Michel, you're asking whether the increase is attributable to an increase in interest in public health. I can't answer that. It's probably one of the factors. We do feel that since we became a school, there is a greater visibility even just within our own university. Students from other faculties have come to us, like at the Journée Porte Ouverte and that kind of event where you try and recruit new students, and have told us, well, we didn't know that you existed. So it's like being a school suddenly gives us greater visibility, and I think that might be a factor. Also, a lot of students are looking for short programs, not necessarily a bachelor's degree or a master's degree, but a micro-program, just to get some skills. again, in public health. Public health is everywhere, is in other professions as well, all the health professions. So we get many, many more applicants interested in those programs as well.
Well, that might be the beginning of a contamination on other sectors to become a health-oriented society. That's what. Monsieur, you've been very patient. Thank you, and I'm back to you.
Bonjour, good morning. My name is Charles Gaji, and I'm a graduate from this school from 1986. I was in the same class as Dr. Paradis. I want to congratulate Dr. Paradis and McGill for organizing this tremendous event. I'm very happy to be here. You were asking Dr. Yu, are you feeling in good health? Yes, I have a good reason for it. I retired from the Pan American Health Organization a few months ago, and that helps a lot. I've been working for 23 years in Pajo, in Washington, so I have a couple of issues, specific challenges I would like to get the reactions of the panel. The first one has to do with, to put it in a nutshell, there was a recent issue of the National Geographic magazine that was the war on science. We know that in the United States we have a new American Galileo, Senator Ted Cruz, about climate change and the denial of climate change. The governor of New Jersey, Chris Christie, required a quarantine for a nurse coming back from the Ebola outbreaks. And we know what happened with the measles outbreak in the United States and the denial of the merits of immunization, the social media, and so on. And I think it's very worrisome, and I'd like to get your reaction to this, because it's not only that people disagree, it's like if science-based arguments becomes counterproductive, at least with some sectors of society. And obviously, it's strengthened by the politics in some countries. The second question is a different one, because people mention the importance of global health, globalization, and because of my experience in Washington with the Pan American Health Organization, I feel, and I'm trying to choose my words well, that schools of public health tend to relate mainly either along language or high-income countries' institution. You know, there's no school of public health from a middle-income country here in front of us to share their vision. No? And I always felt it as a frustration that how can we establish networks and linkages with schools of public health from middle-income or low-income countries, which is very difficult, obviously, because all kinds of reasons. Dr. Paco, there was at least an European master in public health, European public health, between a number of schools of public health of the European region. And I'm wondering, isn't it time to do a master's in public health in the region of the Americas, between schools of public health of the region of the Americas, so that faculty and students do have that exposure to different environment and cultures and thinking? If I'm not wrong, there's not one school of public health in the region of the Americas that is a collaborating center of the World Health Organization. You were there, Dr. Rochon, as Chief of Health Promotion. And I'm wondering this key relationship between public health and not only global health issues, but the main world institution dealing with global health, which is the World Health Organization. What are the strategies or the innovation or that you see in terms of the linkages between your schools and, for example, WHO?
Well, thank you. When you say the Americas, you already mean Latin America.
No, when I say the Americas, I mean, this is the jargon of WHO, the American region, which includes Canada down to Argentina, including the Caribbean.
But a lot of the action...
Not the U.S. No, with Dr. Spencer, I would appreciate to have your comment on this, no, with the Association of Public Health Schools in the U.S.
Thank you very much. Any reaction to those comments? Fred?
No.
Okay. Well, with your cogency and passion, you're not going to stay retired very long. Just two quick comments. One is that you know, you're absolutely right about middle-income countries. It's not, of course, only public health that doesn't work closely with low and middle-income countries, but also medicine, nursing, universities in general, I would say. The National Institute of Public Health in Mexico is a very, very strong institution and collaborates with many of us very, very closely. The Public Health Foundation of India has revolutionized public health training in India. I'm on the board. Many people have worked closely with them, and they now have 750 employees in 4 campuses and are really revolutionizing how people think about public health in that country. That's a huge country, of course, but I think there are chances for middle-income countries to start to thrive. Anyway.
Thank you. Fred and Harrison, you want to? Fred.
I don't have a very precise answer to all the questions you had, but I just wanted to make a comment on the way, because it's a very good example, I think, the way some institutes missed the new health needs of the population. In Europe, I know no institute or schools of medicine who were able to change their curricula to take into account the upsurge of chronic disease in low and middle income countries. For example, Antwerpen, famously, or Heidelberg in Germany. They were extremely slow to change their program and to quit the old tropical health in order to embark these new challenges. And this, I think it's a very important message on, I think, for the future of School of Public Health, if they want to produce practitioners who are relevant for the new needs of the population, they should develop a better system of changing their scopes and changing their curricula.
Harrison?
So this is a common problem. In my country, the practice community always tells us, you don't care about us, you don't pay any attention, none of your programs are relevant, your graduates come out and they're not ready to work. And when, my colleague mentioned that most public health workers, which is across the world and true in the United States, do not have any formal public health training. And then when we talk about degrees, they say, oh, you're disrespecting us because I've been a public health leader for 25 years just because I don't have an MPH or a graduate. It goes on and on. The few faculty that are in the academic situation that are focused on practice issues, whether they be global, whether they be anything else, they have trouble with tenure, their publications are not valued, it goes on and on. I don't know the solution to all this, but I know it's something that I think there are people at every single school of public health that focus on these things. They may not do it successfully. The academic environment itself weighs down. One of the things in the organization, and I've been thinking about it a lot, is what can we do collectively as opposed to collaboratively or only for the benefit of our members? And this is an area that I think is huge. I have no idea whether we'll ever reach any kind of success or not, but I personally believe it is a great lack, but it is really inherent in the academic system of promotion and tenure funding streams and what's valued in an academic setting and what's not valued.
Okay. Very short, Howard, because we have at least another question.
No one tried to answer the first question. I'd only say that risk communication is an incredibly important science of its own. So educating the public on public health risks like the risk of vaccination versus not attaining herd immunity is an incredibly important one. But just one very brief anecdote. When I was at Michigan, we convened a conference to talk about climate change science with the pastors of the largest mega churches in the Midwest. This is the Christian movement that has been fighting the whole climate science thing the most. And we had this very sort of deep discussion of, what is science and what does it show and why do people believe what they believe? And the basic insight that was generated was that we lost them at evolution. Honestly. We lost them at evolution, and it was like, well, if you can't believe the science behind that, why should we believe this kind of stuff, right? Yeah. And it's deep, it's fundamental, at least in the U.S. It's really kind of an interesting situation. But I don't have an answer to that, but I think it deserves a rational and scientific approach, sociological, maybe psychological approach by itself.
Thank you. Thank you. We'll have the last question, sir.
My name is Madhu Pai. I'm a professor here in epidemiology and also the director of global health. Thank you very much for coming. All of you, or most of you, mentioned the growing importance of global health and how that's kind of driving the student demands at your schools. Indeed, we have the same phenomenon here. It's almost as if global health has made public health more fashionable today. And it's a newfound way of rediscovering public health in a new, whatever you want to call it, what was earlier international health and so on and so forth. So what I would love for you to look into your crystal ball, is it a .com that's about to burst, the interest in global health? Or if you think it's real and if it's going to last for a long time, how exactly do we prepare young people for a career in global health? Because I'm sure many people, including Jim, for example, didn't necessarily plan for a career in global health. Like I wanted to be the best epidemiologist I could, and I wanted to work on tuberculosis. It just so happens that these blend well to further something in global health, but I didn't study to train in global health. So how exactly do we prepare for someone in global health? There are master's programs in global health today in Canada, as you know, and we keep wondering, how is it different from public health? And what kind of jobs await these people who get a master's in global health? So how are you as deans preparing for this?
Good. Any reaction? James?
I share your concerns, if they're concerns. The difference of an interest and passion in global health, which I think is real and will continue because of the smaller world and the globalized world we live in, is different from providing skills to people to operate in that environment. So in our global health department, our students still major in epidemiology, biostatistics, behavioral and social sciences. There are also, however, growing in the United States at least, masters of global health, which vary enormously in terms of their curricular content. And I'm on the advisory board of an unnamed university which has such a master's in global health, which provides largely skills in molecular biology, but they call it global health. And that's because their scientists work in other countries in microbiology. So part of the question is, what are we training people to do? And I think the interest is real and will continue to draw people in, but our job, and I think of public health training as an interest in skills-based preparation for job, more of a profession than simply an academic interest. So I think that we need to concentrate on skills building. But there is a difference in the personality of people who work in global health. So our global health faculty, our epidemiologists and health economists and behavioral scientists and environmental scientists, and they have a lot of people in other departments who share this. What they differ is where they work and who they work with. And increasingly, a lot of those people are moving to our own country. So there is this issue which involves, I think, a real concentration, but it's still we have to build skills.
Okay, thank you. Howard?
When I was at Michigan, I chaired a steering committee on global health, and we looked at this issue of global health careers for 2 years and realized that, in fact, the number of slots in so-called classic global health jobs is actually decreasing for our graduates, partly because, rightly so, a lot of the home countries were training their own personnel. But what was insightful was realizing that a global health job is much more than just working for WHO or PAHO or USAID or whatever. It's realizing that our graduates who get a degree in industrial hygiene and then get hired by a Fortune 500 company, which has 15 plants all over the Pacific Rim, and they have to deal with occupational health in those countries. That's global health. You know, our person who's now working in a mental health clinic that's dealing with refugees all over the world who are arriving in Toronto, that's global health. And sort of the global, sort of paradigm is actually critical for really, truly making advances in global health. So we don't give degrees in global health. Actually, we'd rather prefer to train them deeply in epi, biostat. We'll provide a global health certificate or layering on of additional competencies. But that mentality, I think, is our way of thinking of global health careers.
Thank you. Well, unfortunately, that's about the time that we have. If I may, I will take just 1 minute, not to summarize all the discussion, but maybe to come back to the very first question this morning that you raised, sir, in your discussion and consideration about developing as a school of public health as opposed to remaining and developing within the medical school. It just occurred to me that, of course, it might appear from the clinical point of view and from the research groups within the hospitals that there are too many, the world of the School of Public Health is enlarging, and that this seems to be less important. But in fact, it's more sort of enlarging your field of influence, it seems to me, if you become a school, because as the member of the panels mentioned, you would be developing other collaboration with foundations, with other partners working in the practice of public health, as some of you have mentioned, who might not have a title of health or public health, but social actors, municipalities, different groups who are very active and who do need more trained people within their own ranks, so that if we want to link research, teaching, competency development, and what happens in the real life. So in a sense, for what you have now, it seems to me that there should be no question that the numerator will be changed. It will be as important. But if the denominator is greater, then that might appear at the beginning as a loss of importance, but that would have more every collaborator fitting in a larger world. That's a point of view that I think could integrate many of the discussions that we had this morning, but it's just a consideration for you to discuss. So again, thank you so much for all the members of the panels. Thank you to all of you for your very active participation. I know there were many other questions that would have been interesting to discuss. Thank you again, Pierre, for inviting us, and very good luck for what's ahead of you for the future. We need your leadership. Thank you.